Hello, my name is Dr. Dewan S. Raja. Today I will discuss about drug eruptions and emergencies. Eruptions are adverse cutaneous reactions to medications. They vary widely in severity from mild rashes to life-threatening conditions. So these are the side effects of drug on the skin. Common drugs causing eruptions, antibiotics like penicillin, like ampicillin, amoxicillin, sulfonamides, cephalosporin, anticonvulsant like phenytoin, carbamazepine, lamotrigine, NSAIDs, allopurinol, antiretroviral drugs. These are the common drugs. Penicillin includes all the medication which are penicillin group, which are in the penicillin group. Okay. So types of drug eruption, we have axanthimatous or Morabilliform eruption, most common around 90%, onset 1 to 2 weeks after drug initiation. Presentation: symmetric erythematous maculopapular rash on trunks and limbs. Drugs that causes Morabilliform eruptions include all the penicillins and sulfur drugs. Sulfur drugs means cotrimazole, cotrim, okay, or sulfur type of antibiotics. Management: stop offending drug, give antihistamine, and we can apply topical steroids. Most important is stopping the offending drug and giving antihistamine. Okay, this is Morabilliform rashes. Can happen after you start a new medicine. It looks like red, measles like spots on the skin, or it may appear darker in different skin tones. So it will be darker, people with dark skin or brown skin. This is typical on a white race. Urticaria, IG and angioedema. These are IgE mediated hypersensitivity type 1. Onset minutes to hours. Common drug penicillin, aspirin, contrast media. Contrast media we use for suppose to do some type of radiological test like intravenous pylography or intravenous urography or micturating cystogram. So the contrast media contains the substances, iodine group of substances and other components in that substance that may lead to drug eruptions. Risk: there may be chance of anaphylaxis. So this is example of urticaria. Okay, it may be over the anterior part of the body, on the arms, on the lower limb, forearms. It may happen. So there may be chance of anaphylaxis. Angioedema, we are seeing angioedema over the eye. Tongue is very much edematous. It may obstruct the respiratory passage, may lead to death even. Here again, pharynx or laryngeal part very much edematous. Maybe inside, maybe worse than that, it may need tracheostomy. Otherwise, there will be respiratory obstruction and death. Okay, so the lip is very much edematous, swelled up. There may be some type of elevation, edematous elevation on the forearm, on the foot. So these are the features of angioedema. It may obstruct the respiratory passage. Fixed drug eruption, recurrent rash at the same site, appearance well demarcated dusky red plaques, drug like tetracycline, any type of tetracycline, maybe oxytetracycline, doxycycline, okay, sulfonamide, maybe cotrimexazole, trimethoprim sulfamethoxazole combination, NSAID, maybe ibuprofen, naproxen. Lesions may blister in this drug eruption with this drug. Photosensitivity reaction, dose dependent or versus photoallergic immune mediated. Drug like tetracycline, thiazide, this is a diuretic, increases the output of urine, sulfonamide, and antibiotic amiodarone used in cardiovascular condition. Okay. Lichenoid drug eruption presentation, purple polygonal pruritic papules, lichen planus-like, drug gold, anti-malarial, thiazide. Thiazide again, one type of diuretic that increases the output of urine. Okay, so types of drug eruption, drug-induced photosensitivity image we're seeing here, lichenoid drug eruption, there will be thickening of the skin. Okay, severe cutaneous adverse reaction like that of the Stevens-Johnson syndrome, SJS, and toxic epidermal necrolysis or TEN. So these are similar, but in Stevens-Johnson syndrome, less than 10% body surface area detachment. TEN or toxic epidermal necrolysis, greater than 30% body surface area detachment. So something between 11 to 29% are in between SJS and TEN. Onset 1 to 3 weeks after exposure, prodrome, fever, malaise, mucosal involvement always present, oral, ocular, or genital, skin, painful erythematous, macule, necrosis, blistering, sloughing, drug, those cause this problem, like sulfonamide again, we may include cotrimexazole, one type of sulfonamide, anticonvulsant drug like that of phenytoin, carbamazepine, allopurinol, okay, used in case of gout, NSAID, non-steroidal anti-inflammatory drug like ibuprofen, naproxen. So differentiation between Stevens-Johnson syndrome and TEN, okay, is based on percentage of skin detachment. Okay, here in Stevens-Johnson syndrome, it should be less than 10%, but in case of TEN, it should be more than 30%. Okay, so if this is the Stevens-Johnson syndrome, this is the toxic epidermal necrolysis 10. This may be in between the Stevens-Johnson syndrome and 10. Severe cutaneous adverse reaction management, immediate drug withdrawal, the offending agent like sulfonamide or cotrimexazole, intensive care unit or BAR unit admission, supportive care like fluid, nutrition, wound care, controversial management by IVIG, intravenous immunoglobulin, or cyclosporin, but this is not commonly practiced. We will practice this mostly. This can be practiced with the supervision of a specialist. Okay. Drug reaction with eosinophilia and systemic symptom. Onset 2 to 6 weeks after drug initiation. Systemic involvement, liver, kidney, lung. Labs eosinophilia, atypical lymphocyte, drug like anticonvulsant, allopurinol and sulfonamide. Management, again, stop the drug immediately. Systemic corticosteroid we can use. Acute generalized exanthematous pustulosis, rapid onset less than 2 days, feature fever, leukocytosis, sterile pustules, and erythematous phase. Common drug macrolide like erythromycin, azithromycin, calcium channel blockers, okay, like nifedipine. Drug-induced anaphylaxis, rapid onset, life-threatening hypersensitivity. Symptoms: urticaria, angioedema, hypotension, bronchospasm. Common drug penicillin, contrast media, neuromuscular blockers like tensilon. Treatment: intramuscular epinephrine, airway support, antihistamine, and steroid. Okay. Key emergency management principle: identify and stop the offending agent immediately. Supportive care, hydration, temperature regulation, electrolyte management, airway and hemodynamic support, especially in anaphylaxis or Steven-Johnson syndrome. And 10. Multidisciplinary care, intensive care unit, dermatology, ophthalmology as needed. And that's all about drug eruption and drug eruption linked emergencies. If you have any question, please feel free to ask me. Please support my channel. Please subscribe me and please share the information with your friends. Have a nice, wonderful, and blessed day. Bye now.